Welcome, welcome. Nice to see everybody on this pre-spring evening. Not quite spring, there's hope, eternal hope. I'm delighted to introduce our speaker in a moment. I wanted to see anybody in the audience have gout. Oh my gosh, look at that. So all you viewers at home, we have quite a few people here who are interested in gout because they have it. But even if you don't, it's a topic that you may find family members or friends or just be curious about. And we're going to learn a lot about it in a minute. This is actually going to be a fun group presentation today. Normally this is a menu for change. We also have our partnership health folks here. So for those of you who want a little beverage or a little tidbit to eat, there's something in the back, go right ahead. But I would like to introduce Dr. Jane Park. Dr. Park is here in our polyclinic rheumatology department, and she's going to really educate us. Now look at that picture already. That just kind of, it's a little creepy because it looks painful. So that's a teaser. The topic is understanding gout, a common type of arthritis. So Dr. Park got her medical degree from Rush Medical College in Chicago. She completed her residency here in Seattle at University of Washington and also her fellowship. So yay, Seattle. She came to us, I think, last year, is that right? Just 6 weeks ago. Oh, wow. And is a new mom, so she has that mom brain, new mom brain. And we're going to learn a lot about gout. I think the best way would be to maybe hold your questions until the very end, unless there's just a clarification point that you need to make. And please stay late if you want to talk one-on-one, but I'm going to toss it over to Dr. Park.
First, going over some background, including some historical background about gout, risk factors, how do we diagnose it, how do we treat it, and what can be done to try and prevent getting gout in the first place. So gout has been around for a long time now. It was first described by the Egyptians in 2640 BC. And Hippocrates, who is known as the father of medicine, referred to it as the unwalkable disease, since it often affects the legs and can be incredibly painful. It was also known as the disease of kings. So Alexander the Great, Charlemagne, King Henry VIII, all apparently suffered from gout. And back then, it affected mainly men of a certain social status who had access to rich food, rich drink, and as a result, they developed gout. Benjamin Franklin also was a gout sufferer. He even wrote a dialogue between Franklin and the gout in 1780. And it starts, "Franklin, what have I done to merit these cruel sufferings?" And Gout replied, "Many things. You have ate and drank too freely, and too much indulged those legs of yours in their indolence." And I don't know if you can see this little cartoon, but here's Ben Franklin, and he just completed his kite flying experiment. And a woman asks, "Are you all right, sir? That appeared to be quite painful." And he replied, "It's nothing compared to my gout." Here's a print from the 1700s, and it's titled "Punch Cures the Gout, the Colic, and the Tisic." I had to Google Tisic, and apparently that means cough. And you can see a gentleman here who is enjoying his punch, and also looks to be well-fed, and he also has flushed cheeks, so we know that he likes to drink his punch frequently. And both of his legs are bandaged and propped up on cushions, and also his hand. So he has had multiple areas of gout. So what is gout? Essentially, it's the deposition of uric acid crystals in various parts of the body, typically in joints. It can occur in the tendons or the bursa. And this occurs in the setting of high uric acid levels circulating in the blood. And having a high uric acid is very common. and it usually takes years of having high levels of uric acid before somebody develops their first attack of gout. Not everybody with a high uric acid level will develop gout, and it's unclear why some people are more likely to develop gout than others. I'll go over some risk factors regarding developing gout, but still there are people who have all the risk factors who never develop gout. Gout is the most common inflammatory type of arthritis. So the distinction between inflammatory and non-inflammatory arthritis is the immune system is the culprit in inflammatory arthritis. So the most common type of non-inflammatory arthritis is osteoarthritis, which most of us will probably end up getting in one joint or another, and that's due to mechanical forces, wear and tear, trauma, degeneration. In gout, the uric acid crystals stimulate the immune system to cause inflammation and then the subsequent pain, redness, swelling that people experience. By some estimates, 8.3 million American adults suffer from gout, so many, many people, and that's about 4% prevalence. And the prevalence is increasing. Since the 1970s, worldwide, more and more people are developing gout. And there are a number of factors that are contributing to this. Our diet, the Western diet, which includes lots of meat, seafood, alcohol, as I mentioned, increases the risk for gout. But also medications. As the population ages, more people are developing chronic medical conditions, including high blood pressure. And one of the most common medications for high blood pressure are diuretics, water pills, which increase the uric acid level. Other medications that increase the risk for gout are medicines that are used to treat or to prevent organ transplant rejection. Those are notorious for causing gout. Gout in and of itself is also associated with other medical conditions, even if you're not taking those medications. So people with high blood pressure have a higher uric acid, obesity is associated with higher uric acid, diabetes and chronic kidney disease are all associated with higher levels of uric acid. So moving on, there are 3 stages of gout. The first is the acute gout attack, which most of us are familiar with, and I'll be going into more detail about each of these stages. Intercritical gout, which is the period between gout attacks, and tophaceous gout, otherwise known as chronic gout. So the acute gout attack usually involves only one joint, typically in the legs. The base of the first toe is a classic location for a gout attack, but the knee is also commonly affected. It can affect other joints, bursa tendons, as I mentioned. Even the spine has been reportedly involved in gout. As somebody who has gout, if they have untreated gout or poorly treated gout for a longer duration, then multiple sites can then be affected by a gout attack at the same time. So it's not uncommon to see somebody with a gout attack affecting their foot, their wrist, their knee, all at the same time, and it can be very, very painful. As I mentioned, gout is characterized by severe pain, redness, swelling, warmth, and the symptoms often do peak within 12 to 24 hours of the first onset. The inflammation itself can extend beyond the joint that's primarily affected. So here is a photo of someone's foot, and at the base of the first toe, we can see it's red, it's swollen, and the redness even extends sort of into the middle part of the foot and even into the area of the second toe. That is very common. Fever can often happen in gout. Usually that occurs in patients who have had gout for a long time, or if they have multiple areas of gout involvement. And that can be tricky sometimes since if somebody comes in with a red hot swollen knee and a fever, we worry about an infection. So we have to rule things out to determine if somebody has gout. And interestingly, gout attacks usually occur at night between midnight and 8 a.m. So it's not uncommon for somebody to say, I just woke up and my foot was inflamed. And there are a number of reasons why this is. One reason is that nighttime we're in a state of relative dehydration so that the uric acid concentration increases, and then the uric acid can then precipitate and form crystals. Also, our temperature goes down at nighttime, and with a lower temperature, the uric acid is more likely to form the crystals. An acute gout attack, without any treatment at all, will still resolve. So I often see patients who had a gout attack or experienced something that seemed like a gout attack, but then they didn't seek treatment because it just went away. But the duration of an acute gout attack can increase over time if somebody does not get appropriate treatment. So the second stage is known as intercritical gout, and that is the time period between acute attacks. And this is a period where people feel fine. When you look at them and they walk in the door, their feet look completely normal. And this is very characteristic for gout, where there are periods of intense inflammation and then periods of no symptoms at all. And the duration of intercritical gout can vary. It could be months, it could be years. I've had patients where their first gout attack occurred at the age of 40, and then their second one was at the age of 60. But if somebody's living with a high uric acid level, over time, the frequency of the gout attacks will be increased. Tophaceous gout, or chronic gout, is a third stage, and a tophus is essentially a nodule, a collection of urate crystals, fibrous tissue, and inflammatory cells. And they can present on the ears, the joints and tendons, and essentially anywhere that a gout can attack. So here we can see there's a little tophus on the cartilage of the ear. This is the bursa of the elbow. So not the joints, the fluid-filled sac over the edge of the elbow. And there are multiple tophi here. And this person's hands, unfortunately, there are multiple tophi over the joints. And there's subsequent deformity of the hands. And here, again, at the characteristic base of the first toe, there's a tophus that is grown quite large. It's actually extending up the middle part of the foot. And despite their appearance, tophi are generally not painful or tender, but they can lead to joint destruction because of the inflammatory cells that are present. And while tophaceous gout tophi are kind of the hallmark of chronic gout, they can rarely develop even in people who have never really experienced an acute gout attack. That's pretty rare. So what are the risk factors for developing gout? Men have a higher uric acid level than women do before menopause. So men have a higher rate of developing gout. Women pre-menopause, the estrogen levels have an effect on the kidneys' metabolism or processing of uric acid. So the estrogen is protective, and then post-menopause, the uric acid levels rise to the same level as men. Asian and Pacific Islanders have a higher rate of gout, and that is probably a result of genes associated with higher levels of uric acid. There's some Pacific Island nations where the prevalence of gout in men over the age of 65 is about a third, so very high rate. Obesity is a risk factor for gout, and there are a number of dietary factors that increase uric acid, as I mentioned. Beer and hard liquor increase the risk for developing gout. Interestingly, wine is not a culprit for developing gout, but if somebody does have gout already and they're drinking excess wine, excess being 2 glasses or more a day, then their rate of attacks are more frequent. Meat and seafood are known to have high levels of purine. So uric acid is the end product of purine metabolism. So eating a lot of purine-rich foods increases the risk for gout. High fructose, this is has been identified as a culprit more recently. So anything with high fructose corn syrup or drinking or taking in a lot of sugary foods increases uric acid. And as I mentioned, high blood pressure, using diuretics, chronic kidney disease, and organ transplant recipients have a higher rate of gout. So how do we diagnose gout? Ideally, what we would do is if somebody walks in with a red hot swollen knee, we would take some fluid out and look for the uric acid crystals. And here's a picture of the uric acid crystals under the microscope. But sometimes we just aren't able to do that for whatever reason. We're not able to take out fluid, or it's a hard place to get the needle in. Then we can try and diagnose gout based on the clinical history and the symptoms. So if an 80-year-old man comes in describing attacks of pain, redness, and swelling in the base of the first toe, he has high blood pressure, and his blood tests show high uric acid, we can be pretty confident that he has gout. So how do we treat it? Oh, and I forgot to mention, there are other imaging studies that could be done to try and confirm that, but those are the 2 main ways that we diagnose it. So how do we treat it? There are a number of ways. If somebody comes in with just one joint that's inflamed, we could try and do a steroid injection, which would get right at the site of inflammation without exposing you to other medications systemically. But if there are multiple joints involved, then we think about using anti-inflammatories. Indomethacin is a commonly used anti-inflammatory for gout, but even ibuprofen or naproxen leave is helpful for gout. Steroid pills, so prednisone and Medrol, are often used as well, which is also very effective for acute gout attacks. And colchicine, it's an old drug that is often used for gout. It's most effective if we use it 24 to 36 hours of onset of symptoms. So now that we've treated somebody for their gout attack, how do we try and prevent it from happening again? Well, we don't necessarily treat everyone with gout with long-term medications. If somebody just comes in with one gout attack and they have no other symptoms, then we might think, well, let's see and watch. We may not need to start a medication. But if somebody is having frequent gout attacks, frequent being more than 2 a year, or if they're disabling, so if somebody has one gout every 2 years, but they're laid up for weeks, we might want to start that medication. Anybody who has joint damage from gout, we definitely want to start treatment so that we can prevent further joint damage from occurring. A toe fist is a sign that we need to start medication. Like I said, the tophi occur in chronic gout. And then the last 2, kidney disease and uric acid kidney stones, it's a little less certain, but we often do consider starting treatment. There's a lot of interest now in lowering uric acid in some patients who have chronic kidney disease, and there's some data that lowering uric acid may improve kidney function. And then in terms of the treatment options for long-term medication to prevent gout attacks, again, there are several. Allopurinol is an old one that is commonly used. Fluvoxostat is a newer medicine, works very similarly to allopurinol. It is a brand name, so it's more expensive. Probenecid, an old drug, not quite as effective as allopurinol and fluvoxostat, but still used. Lesinurad or Zorampic, that was just FDA approved a year ago. That is only used in conjunction with allopurinol and fluvoxostat. And then pegloticase or Krystexxa, that is an IV medication, and that is used for tophaceous gout, kind of the most severe cases of gout. It is very expensive, and there's a high rate of allergic reaction with that medication, but it is very effective. So how do we try and prevent getting gout in the first place? The modifiable things that we can do mainly have to do with diet. So studies have shown on multiple occasions that diets high in low-fat dairy reduce your risk for gout. And a diet high in low-fat dairy is essentially drinking 2 glasses of low-fat or skim milk a day. It's been shown that patients who take in that much dairy compared to patients who drink no dairy or high-fat dairy have a lower risk for gout. And again, diets low in meat, seafood, sugar-sweetened beverages, beer and spirits can reduce the risk for developing gout. Also, weight loss. We know that obesity increases the uric acid levels. Losing weight lowers the uric acid level and reduces the risk for gout. So in conclusion, gout is a very common type of arthritis. It can cause attacks of severe pain that will eventually resolve on their own. But we do have effective medications. The risk increases with age, male gender, diet, medications, and is associated with several other chronic medical conditions. And gout is very treatable. We know that gout is undertreated in the US and worldwide, and it's unfortunate just because we do have so many effective medications. If untreated, attacks become more frequent and permanent joint damage and deformities can occur. And while diet does have a role in gout risk, in terms of increasing the uric acid, medications are much more effective in lowering the uric acid level. Even the strictest diet, cutting out all purines, cutting out all alcohol, can only lower the uric acid by so much. The medications are really much more beneficial. So here are a few websites that can provide more information: gouteducation.org and arthritis.org. Any questions?
So I'm curious about the seafood. Is it really like more shellfish and prawns, or are we talking salmon?
Yeah, shellfish, mussels, sardines, anchovies, those are the big ones that increase uric acid. And then the meat are the organ meats, so liver, kidney, sweetbreads, but also fatty red meat increases uric acid.
If you're going to eat seafood, salmon's like the best choice, right?
Yeah, that is not as notorious for gout.
Are you talking about diet history over weeks and months, or will if you eat a bunch of shellfish, it might present in hours?
Oh, well, in somebody who has established gout, that I have heard that somebody comes in and tells me, I ate a bunch of crab.
So it's a trigger then?
Yeah.
Okay. Could be.
Although I will say the studies haven't borne that out, that the diet can precipitate a flare, but I have patients tell me that all the time.
Again, if you work on a diuretic, would you just, with a lot of hydration, would that reduce the uric concentration?
It can help, but depending on the uric acid level, it may not be enough to get you below a level of not having gout.
Yeah, I've had quite a few people tell me that black cherry juice or something like that, black cherry extract in terms of pills is helpful. Is that the case?
So there have been studies about cherry juice, and that may help during a gout attack. But it hasn't been shown to prevent gout. And those supplements that have cherry extract, it's not clear how much cherry extract is in there, how much do we really need. We just don't know that yet.
So I started having gout about 7 years ago when I turned 40, and I did all the dietary restrictions you said. No more mammal meat, no seafood. Got to the point where even eggplant would trigger harsh attacks, to the point where you were saying, cut out all purines, you're still going to get it. I got to that point. So then I got on allopurinol about 6 months ago, and that really helped. Am I on allopurinol for the rest of my life?
So that is interesting. So there is research going on now about whether we can stop allopurinol. But the thinking is probably not. Because if you're somebody who is probably genetically susceptible to developing gout, that genetic susceptibility isn't going to go away.
Yeah.
So you're most likely going to need a medication. But the good thing is, I mean, I have patients who, yes, they have to take a daily medication, but once they get their uric acid level at goal, which is less than 6 milligrams per deciliter for most people, and they're able to maintain that, they will never have another gout attack.
Is uric acid related to other forms of arthritis like psoriatic or rheumatoid?
Not as a causative agent, but people who have psoriatic arthritis are more likely to have gout. And the thinking behind that is if somebody has severe psoriasis, there's a lot of cell turnover in the skin, and that raises uric acid levels.
Yeah, some of that finger joint presentation made me think of that. Interesting.
Does everyone with chronic gout end up getting tophus?
No, not everybody.
And if you're on allopurinol, you're not going to get it probably?
You probably won't, especially if your uric acid level gets to a good level.
You mentioned that gout is more common with kidney disease, kidney problems, and a lot of the medications you listed are usually not used like the anti-inflammatories for people with kidney problems.
Right.
Are some of them more acceptable for those people?
Yeah, if somebody has bad kidney function and has a gout attack, then we would think about maybe doing an injection or using steroid pills. And colchicine even can be used. We just have to be careful about the dose in the setting of kidney impairment. If we're talking about long-term treatment, we can use allopurinol too in people who have kidney problems. We just have to be a little more careful. But it can be used too.
So we talked about chronic kidney disease. Online, it can be a little confusing. I think clinically, chronic kidney disease is a glomerular filtration rate of 60 or lower. But Big Pharma will tell you, well, you have stage 2 kidney disease if you're less than 80. What's your definition of chronic kidney disease?
Oh, well,
Or do you
that's a good question. I mean,
go ask a urologist?
if somebody has mild, what is mild kidney impairment? I mean, I guess I would go by less than 62.
I might chime in and say that I think it's hard to define just by that one test.
Yeah.
So, the GFR, glomerular filtration rate is one test. There's another called creatinine. There's also another test looking at urine protein levels or microalbumin, and I think it's kind of conglomerate. So it's a little bit of a fake. I just use that one. I know what you're talking about, though, in terms of like ranges. I think maybe just generically, anyone who has older kidneys or who has a very low GFR, that's kind of the warnings on that, I think.
Yeah.
Well, if you want to stay around a little bit later for one-on-one, I just wanted to say, first of all, thank you so much for your presentation. And I think we have some potentially low uric acid producing food in the back, maybe, or some water. And please fill out a survey at the very end in terms of comments on the talk today, and have a lovely evening. All right.